Of course, the pharmaceutical industry. I mean, we're the only country which allows direct-to-consumer advertising after the United States. The industry obviously has shareholders, and the expectation is they sell as much of this stuff as possible, and so they will find ways of getting to promote. So a lot of papers and journals come up with this. This is the international standard of care. If you don't do this, you're useless. And these are very often single papers sponsored by drug companies pushing their drug. A lot of consumer groups are sponsored by pharmaceutical companies to create demand. So there's an industry there, and you know, we understand what the industry is about. None of us are shareholders here, of course. No. But basically, they're there to encourage maximum use of drugs. Very powerful, very wealthy industry, very politically strong, very strong in the government. Yep. But of course, the pharmaceutical industry isn't all bad. Geez, we wouldn't get half the stuff. You know, they've also got a role. We just got to understand their role. So the worst culprits, this is the study in 2005. That hasn't been replicated in New Zealand. I was very glad as a psychiatrist that none of my drugs made it onto the list. These are the drugs most associated with adverse reactions and readmissions to hospital in the frail elderly population. Less smug when you look at the combinations of drugs, that the ones I prescribe are well represented in the top 3. So basically the main problem is combinations of drugs rather than single drugs. And a combination of anticholinergic drugs or blood pressure lowering drugs or sedating drugs cause all sorts of problems to the elderly people. So we get to deprescribing. There's a literature on deprescribing, but it's not a very big one. And in fact, there's no evidence-based guidelines, so we don't have guidelines to show us what we can do about this. When everyone writes about it, they've got to take life expectancy into consideration, but we don't know when the end of life starts. So it's not 2 weeks before you die. It's sometime quite a long time before that. So people are dying quite a long time before. So for example, the people we see with dementia, we're starting to talk about dying really quite early on in the piece because they have a terminal illness, basically. And so we need to introduce this idea of palliative or non-aggressive medical care at some point in our dealing with people as they age. And nobody quite knows what, and nobody is going to get up and be the flag bearer of this in the New Zealand community because you will be vilified. So that brings us to our multi-intervention approach to polypharmacy. So this was a working group which was convened in the central region, Wellington, just down the road there. Started in 2012. So we had a very good brief. Just sort this out. Come on, guys. But don't spend any money. And it was a very interesting group. I mean, there was pharmacists, some experienced nurses, geriatrician, GP, psychiatrist, a bunch of people who actually, it was a very interesting group. We were all a bit cynical when we got there. We thought, oh, geez, that? What the hell? So we started out doing a literature review, and we looked at what all the district health boards were doing about polypharmacy to see if there were any ideas what we could recommend. And some of what I've kind of already presented is from the literature review. So what didn't work? So you look at the literature, what doesn't work? Guidelines and flowcharts don't work. That's what we all do. We give guidelines and flowcharts. Basically a guideline to manage polypharmacy in old people is a thick book like this, which you pin to the wall in the ward and nobody will ever look at it. It's too complicated. And same with flowcharts. Flowcharts are just so complicated they can't be used. And so they don't get used. So people who've done flowcharts generally find they don't make any impact. So what interventions do work? Well, to start that slide, well, firstly, no particular intervention has been shown to work. So that's the disclaimer. But there's elements that have been shown to be most effective. So the involvement of pharmacists, primary care, need of a geriatrician, input to give advice on the complicated cases, and of course, spending time talking to the patients. So you could just immediately think of the costs of all of this. Oops. What have I done? So our conclusion was there's no single solution. It's not going to be possible to change the whole system because we think the whole system needs to change. We all need to change the way we look at elderly people advanced care planning and palliative care and everything, but that's never going to happen. So our decision was to try and create demand from the patients and families, demand a change from the grassroots, and then try and change people's behaviour that way. So, and we understood that if there was a demand from patients and their families to cut down the number of drugs, that would go to the GPs and the pharmacists. They would need support and advice and education. And we were very aware that this could be potentially costly. So we developed a series of leaflets. These fold into 3. That's not how it looks. It's an 8. So it folds into 3. So basically to be put for the patients and their families at various prominent places, like in the hospital, outpatients, and in the GP practices and pharmacies, with a message of, am I taking too many drugs, basically? Don't stop taking them without talking to your professional. And this is not how it is actually presented in the fold, but I mean, basically that's the message. So it's a message about the potential hazards, the potential adverse effects you could get from polypharmacy, and what you could do. Go and see somebody, talk about it, and ask whether it's possible to cut back on some of your drugs. Don't stop your medication without medical advice. See that twice. And we created posters which were available at the GP practices and places, pharmacies and places where the professionals would have some sort of idea of what people were coming to them about. Oops. In addition to that, we decided that there would need to be an educational opportunity for general practitioners and other primary care professionals to upskill or up their confidence before they're confronted with this mass of elderly people wanting to cut back on their pills. And we also realised that there'd be a need for a specific specialist involvement on the complicated cases, which would involve a geriatrician and an experienced pharmacist. And thank goodness, Wanganui put their hands up and said, yeah, we'll do this as a pilot. So Fiona, do you want to just talk to the next couple of slides, basically?
This is the report from the pilot, which you can get as a PDF at the link. And that was, we changed all of the posters and the brochures based on discussion that we had from Ian's working group to our comms team at the hospital. The DHB worked with the comms team at the Primary Health Organisation, and we went through quite an iterative process and a lot of debate about the wording of the brochures, and so that's kind of a mock-up of what our brochure looked like. Yeah, and so the first, the pilot started off in, we had our first meeting at the end of 2012 where the HOP, the group that Ian was on, that did all the pre-work, invited Wanganui to come along, and we were late to the first meeting, and then we got told that we were the pilot site for this project, but there was no extra money, so we had to try and reconcile that in our daily work, and it was all a bit fraught at the start. But the first 6 months of the project were the awareness raising campaign, and as Ian said, the pharmacists and things weren't really involved in a lot of that, but the comms team got brochures out to all of the rest homes and general practice surgeries and posters, and we even had some in the local mall, and we went to all the aged residential care facilities, and there was a lot of, there was basically saturation of the local DHB area with all of the awareness raising stuff. And then the SMAS, the Specialist Medicines Advisory Service, was based on the pathway that we already had in primary care. So clinical pharmacists were responding to referrals for medication reviews from the general practitioners and from people walking, self-referring and things, but the pathway allowed us to have a more formalised referral upwards to the specialist geriatrician and the general physicians at the hospital. So if there were cases that were outside of our experience and scope, we could get support, refer the cases up to the specialists for an expert kind of opinion, and the GPs could also, if they'd already referred people to us for a medication review and we'd done what we could, they could directly refer to the specialist, which was kind of a pathway that hadn't been available to them before. So this was our response to, or our support mechanism that we set up in anticipation of all the demand that we were going to get from our awareness raising. And we looked at 75 patients referred between August 2013 and 2014, and we followed them up. We did the reviews and they went through the pathway, however it fell for them, and then we followed them up after 6 months and did some analysis of what happened to them. So these are the results. The mean age of the 75 patients was around 7 and a half, and the median was 81. Most of the referrals, I think all, but about half a dozen were either GP referrals or they came from patients that were in aged residential care. And the aged residential care, a couple of the big rest homes got really involved because they were really interested in getting people off, the residents off a lot of their medicines. And the cumulative medicines risk score significantly reduced from baseline, and this cumulative medicines risk score was a metric developed by Professor Tim Mayling, and it took into account not just the number of medicines but things like risky conditions, so if they'd already had a fall or if they were blind or things that would kind of amp up the risk of the medicines, and also took in, there's quite a few different criteria in calculating this risk score, including if they're on high risk medicines. So polypharmacy, as Ian's already pointed out, is worse if the medicines are high risk medicines and things like that. So, and the cumulative risk medicine score significantly reduced from baseline, and most of this was attributable to the reduction in the number of medicines. A lot of the other things, the other dynamics didn't really change, but the number of medicines did. And most of we could make recommendations in our reviews to stop, modify doses or whatever, review a medicine if we weren't quite sure what should happen to it, or add a new medicine. And most commonly our recommendations were about modifying doses and changing times and things like that. And after 6 months, we went back and had a look at what had been implemented and obviously recalculated the medicines risk score. And there was 73% compliance with recommendations after 6 months. And then one of the issues that we commonly face with is about the time that it takes, and GPs, struggle. And in my presentation later, that's one of the biggest criticisms we get faced with, that it's the time that you take to deal with polypharmacy in practice. And so we calculated time as well of everybody involved. And for the face-to-face and MDT meetings with the GP, and sometimes if it was an MDT, the nurse was involved as well, they ranged from 5 to 15 minutes per patient. So this was in a 6-month period. So the actual face-to-face time of meetings, while people have this perception that it takes a lot of time, it didn't actually bear this. The trial didn't actually bear that out. And we calculated some savings just on the basis of medicines avoided from the reduction versus costs, and the costs were calculated a cumulative of the GP time, the pharmacist time, and the printing and all of the stuff around the awareness raising campaign, and the ratio of savings was cost to twice the savings for the cost. And there was also some qualitative analysis of patients and prescribers. So patients that went through the process got a survey that they filled in and sent back, and prescribers, the prescribers that were involved also got surveyed, and we got a few back from that. But the patient-oriented outcomes that came through in the evaluations were that patients did feel empowered to question their medication, so that was a good thing about the trial. A really big one that came through was that there was less pills to swallow, and reduced medication did improve quality of life for both the patients and the people that were looking after the patients. And another thing that came through was for us to do this and to be able to manage it, the whole team needs to be engaged. So prior to the trial, when we didn't have the formal kind of pathway set up and defined as part of the development of SMAS, the pharmacists that myself and my buddy Sala, who were doing the reviews, we would sometimes get, and this comes through in my presentation too, we'd sometimes get to the point where we'd done the review, we'd got the referral, we'd done the review, but then the process would fall over because different parts of the team weren't engaged. But setting up a formal kind of pathway and where to go and what to do next really helped everyone to be engaged and to get plans implemented. And the other thing that we found out was that sometimes you can make all these wonderful changes, but they need to be reversed. So, you know, it's a dynamic thing. So sometimes you have to be prepared to go back and undo some of the deprescribing that you've done. So, yeah, it's hopefully.
Thank you very much.
Hopefully, all right. Thank you.
I mean, as a person who was seeing Wanganui do this from the outside, I mean, they did a remarkable job. It was a really good piece of work that they did, and they embraced it and they improvised. And I guess it shows that what can be done if people actually buy into the idea. So none of us are sitting here saying this is the answer to polypharmacy, but this is one way we can approach it. And there are ways that can address it. So to kind of finish off, you know, as I've said already, it's no easy solution. Most of the drugs that people are on are actually indicated. They're not contraindicated drugs. It's not easy to say, oh, this is contraindicated, stop it. Actually stopping drugs that actually are indicated. So it does make it more complicated. And this does require discussion, and it does strongly require the involvement of the GPs and pharmacists. And really that leads into the rest of our presentation today, where we're going to hear from other professionals who have advice and ideas on how this can be addressed. So I'm quite happy to try and answer any questions. I've got about 8 minutes or so. Yes.
I'm thinking that it's important to have a family member. You've got that there on the slide.
Yep.
Because it leads into end-of-life discussions as well, and how you can manage that. And you have to have the family on board for that.
Yeah, absolutely. Because part of the discussion is we're removing this risk-reducing drug, which means you've got a bigger risk, potentially.
What's the role of using blister packs in things to manage administration and making it easier? Where I am, we feel that blister packs are hugely important to this conversation, but funneling about that is an issue. But so in your pilot, is everybody always speaking to more than 1 or 2 medications on blister packs or not?
Yeah, so there's no rules. In our area, we are lucky that by some weird process we do have access to funded blister packs.
Right.
And that's via a separate process which is outside of the MIAP, but it's pharmacists that do medicine use reviews.
Yes.
As part of that service, our DHB clicked on blister packs where they were indicated, but they are very important, and you're right, and I'll talk about that in my presentation, that especially tapering and stopping things.
Yes.
Where there's changes happening, it's virtually impossible to do that without some sort of adherence support like a blister pack.
Cool. So I just wondering if we are in a similar place to get that funding, but just thinking ASH funding, that'd be an area that would be useful.
I mean, my job is seeing people in their own home, and I always look at their drugs and say, I want to see the drugs, show me in boxes and bags and stuff.
Yeah.
Where's the blister pack? I mean, it makes a huge difference, and it is something that you can then control if people
Yeah.
got confusion. So,
Yeah, I thought that was fantastic sort of opening and exposure of the root cause analysis problems that we've got, really. In translating that into a clinic like my own, which is quite big, maybe doing some fairly major things within it. So have you thought about getting your work peer reviewed to the extent of getting some analysis about the validity of the conclusions one comes to, or are we going to take this as the beginning of the thinking and testing that we all do in our own environments? And it has major impacts one way or the other on the day-to-day life of the GP. Because finding 15 minutes for a number of people, and I've done, searched a few of my records to see what's going on, and it's frightening to think how I'm going to find the resource to be able to do very much with them unless my job changes. So somewhere we're going to need some evidence that someone has to find the resource to apply some time to make some decisions on which we're going to make some changes, or we're going to have to struggle our way through. But you've given some clarity about where we need to struggle.
So the short answer is no. Basically, this project finished at the pilot. There wasn't a budget anyway. I mean, a project like this needs to be more extensively done to really produce evidence that's solid enough to make the government change its funding policies. I do think that having the demand from the ground up is the right way to go, personally, because it does make it a lot easier for you as a GP. If somebody comes along and says, look, I'm on too many pills, I want to stop some, then you having to introduce it and say, look, you're on too many pills, I think I've got to stop some. It's a different dynamic. So I think that idea is quite solid, but everything that spins off of that, there's no good evidence to answer that question.
You mentioned that most medications were indicated, but did you look at off-label prescribing? You see vogues like sublingual-typings. Sleep.
I personally didn't look at. I mean, when you look at pharmaceuticals, generally in polypharmacy, most of them are indicated. Of course, within that there'll be all sorts of things. People get amitriptyline to help them sleep. They'll be getting.
I think if you look at disease-specific or symptom-specific conditions, like there'd be a lot of polypharmacy off-label prescribing.
I mean, the paediatricians argue that all of this stuff is off-label, and I guess when you're looking at frail dementia, frail elderly people, yeah.
I was going to just raise the fact that what we're talking about is a big bang. One day you come along and people's drug chart would be right, or rightish, or better than it was. But the other approach would be to have some way of evidencing the fact you've considered all the indications for the medication every time you hit the repeat button. And I don't know, show of hands, who did the polypharmacy audit for the college. It's a bit frightening. And I can't remember the acronyms now, the Health and Safety Commission, how many patients with over 11 medications in your practice? Well, it's 800 in my practice. It's quite frightening. But I mean, it does raise questions like, there's another audit, records review audit, saying, are your long-term medications, do you know what the indication is? If you don't have documented the indication along the prescription, how can you expect the patient to know what the indication is? When you have to actually go through 20 years of records to find out what the original indication is and if it's still valid. So, I mean, I'm moving towards trying to prune as you go, rather than having a big bang. Because it will all right on review day, and then it will go change as clinic letters are read or not read, or ignored, or whatever. But anyway, what I'm saying is that kind of, I'm struggling to find a tool to evidence the fact that people have actually stopped and thought about the medication, what the indication is. You do a record review audit, they say, when was the medication reviewed? Well, I can say someone pressed the button on that day, but the only evidence I can find is a diabetes annual review where there's a tool to make you consider the list of medications, or cardiovascular risk assessment. Those are the only people who have got hard evidence that their medicines were actually reviewed systematically. Everyone else, who knows?
And I think I'm going to talk about this as well. You kind of think I put my
But I think medication review means different things to different people, and so you know, like we see in rest homes where the GP's been up and done the 3-monthly review, and it's a stamp and they sign it, and that's not how we do a medication review. So we'll speak to some of that.
That's a really good point. And an extension of that now, sadly, under long-term conditions funding, is that I know a lot of practices are taking, you know, they've got polypharmacy or medication review as one of their criteria if they were to receive review, so the government's going to pay for that, or PHO, government, and then they just give them their medicines. I mean, we just use that, oh yeah, we use that one for their 3-month medicines. It's just disgusting.
So we just got a couple of far away.
I was just wondering if anybody has looked into that idea, because I have come across some scripts that I repeat where it says that take 1 tablet BD against high blood pressure and to protect your heart or something like that. Would that make a difference if we had to always write the indication in a way that the patient understands it, but also to remind ourselves? If people look into that?
No, I don't know. I mean, I think all of those would be helpful, but I think it's very difficult to change this because they do have high blood pressure and they do have diabetes, whatever it is. As I said, most of the evidence would show that most people are getting their medication for the right indication. Their medication for the right indication. Anyway, we've got to move on.